For joining us today for the second part of our series in the Student-Teacher Professionalism Partnership. Just confirming that everyone can see my screen. Yes, Christine, we've done that check. We're all good?
Yes.
Okay, wonderful. So this is definitely a collaborative effort. A few of us driving with lots of inputs from colleagues in different spaces. But today, myself as the clinician coming in, my name is Dr. Ingrata, and we've got Prof. Cook online with us. Dr. Bukina has also been integral to this discussion, but she's currently on sabbatical, and Dr. Mukachan is going to step in and assist us going forward. So this was a series in 3 parts, and last week we looked at what is the role of the doctor role modeling in the professional development of learners. And we discussed and reflected on faculty, on what are our roles in this space and what are we role modeling. And I asked for you to be quite introspective in this. Today, we're going to look at some tools to both teach and assess professionalism. And then next week, for the last part in this series, we're going to look at the way forward with the introduction of a student-teacher professionalism partnership. So last week, I took us down the uncomfortable space and asked you to zoom into your training space and yourself and to look at what is your role in role modeling professional behavior. What are you as an individual role modeling? What are you seeing happening in your space? And to consider how receptive you are to receiving feedback around this area. And are you practicing what we are professing to teach our students in the development of professionalism? We also looked at what makes a good role model and the positive effects that this has on student professional development. So going forward, today I'm going to take you through the tools that exist to teach and assess professionalism. And this is not by no means a comprehensive exercise. It's just a dive in to look at some tips, tools, and strategies that might help guide you that you hadn't considered before. So the outline for my talk today: we're going to reflect on our personal experience in a particular area, and then we're going to walk through some tips to teach professionalism, tips to assess students in their professional behavior and the development thereof, and tips to assess teachers and how they're doing in this area. And then at the end, we'll look at what is the way forward based on this topic. So to start off this conversation, I am making assumptions that most of the people in the room are healthcare workers of some type and have practiced in some way. But today, what I'm going to ask you to do is if you have ever been a patient yourself. And I want to ask you to reflect on your experience as being a patient. This could have been a visit to the doctor's office, a stay in the hospital, a visit to the physio or the chiropractor or the biokineticist. Perhaps a nurse came to your home to care for one of your family members, or any other healthcare related interaction where you were a patient or a family member of yours was a patient. And then I want to ask you to think about what qualities did the healthcare worker possess that make them come across as truly professional. These could include things like the way they communicated with you, empathy, knowledge. Perhaps they came across as being very competent. And I posted a Jamboard today, and I know it was early, but this is just an interactive tool that I'm going to switch to quickly to look at kind of some of the ideas that colleagues have come up with. So I'm just going to change what I'm sharing and switch across to this one. Can you all see my Jamboard?
Yes, we can.
Richard, we're good. Okay. So what I asked, and I'm not sure if people took a look, I put a couple of options on here. And I wanted us to think about what qualities separate a professional from an unprofessional healthcare worker. And what might make it easier to think about this experience is, how did the healthcare worker make you feel? What about the way that they were behaving made them come across as professional or unprofessional? So I've placed some examples on here. And for those of you that know how to use a Jamboard, please feel free to populate this as we talk. You're also welcome to just put up your hand or comment in the chat. But I'm just going to start off just to get the juices flowing For me, my family general practitioner growing up, I'll never forget him. He was one of the reasons I wanted to do medicine. And he was always so gentle and welcoming. He made me feel safe, and I went there lots as a child. I've seen doctors that sit down at the level of their patient and they allow for questions. They literally take a chair down and they sit, especially if patients are in bed at the bedside and they're sick. They have to come across as knowing what they're doing for me. And the ones that really stand out is those that treat the patient as a person. I see someone's popped in there, listened to me and spoke to me like I'm a human being. And perhaps they explained their uncertainty, but ironed out a plan to explore this with the patient. These are the things that I could come up with and some colleagues have come up with. But if I look to the chat, I see that there's a hand up, and let me go to that. Jennifer, would you like to share?
Yes, I think my experience, I've been admitted 3 times with serious problems, but each time I was a doctor, so I'm not sure if that changed people's experience. I had a stroke with one, and the guy I've known for years and years and years. He was really nice. He spoke to me beautifully. The other one, I had a pulmonary embolus, and they were very nice to me too. And the other one, I had an ischemia of bowel resection, and that one I was much younger. But each one, the people were really good to me. But I'm not sure whether I'm judging them because they treated me as a doctor. So it makes it a bit difficult to know if they're treating everyone the same. But that's just my comment. Thank you. Did you hear that?
I did. Thank you, Jennifer.
Okay.
In fact, my experience was different. I was a patient, and once they found out that I was a doctor, they in fact turned everything into medical speak, and I was quite overwhelmed by it because it wasn't an area that I was well aware of or had a lot of knowledge on in that area, and I just would have loved for them to have rather treated me as a patient that knew little to nothing rather than to assume. But I'm glad that your experience was the opposite. And I wonder if that's changed the way that you interact as a patient with your doctors, given that experience being so positive. Mine is the exact opposite. I don't tell my doctors that I am a doctor to start. It comes in later, just so that I get a different sense. Any other comments here? So if we look at the unprofessional elements that were reflected here, being rude to patients because they had missed an appointment. This is something that I see every day in the medical outpatients where I work, where patients really have legitimate reasons for not being able to get to the hospital, and they miss appointments and they come on the wrong day. And some healthcare workers really start off on the back foot here and start berating patients for skipping medication and missing appointments, and they're really not treating them as human beings where things could go wrong. And I find that incredibly unprofessional to witness. Any kind of shouting at any level, but particularly juniors and or allies. Uncovering the patients with students to see the genital area without screening and putting the curtains on, treating patients like objects. Really, this was quite poor. And this happens all over. Often I feel that I know that things are going wrong because I feel uncomfortable when I observe unprofessional behavior. And I must say it's quite difficult to step in, especially if it's a peer that's a good friend of yours or a peer that you maybe don't get on with, or in fact a senior person to you to step in. And I see there's a comment that's been placed. I went in without introducing myself as a practitioner, and I felt that there was not an attention to detail, and this influenced my expectations of communication. So if we look at these things and we look at our experiences as patients of professional behavior, I wonder if any of us have like a built-in metric for how to behave, and we kind of measure our behavior against someone, or if we just behave because that's what we do and we don't really pay attention. I'm going to step away from this personal experience as patients for now. I don't know if there are any other comments that people want to add in at this point. Richard, anything you'd like to add at this stage?
Just to reflect briefly on my experiences being a patient, I too have tried to step away from being identified as a medical professional, unsuccessfully, to be honest. Because, well, I guess if one's in the circles round and about Gauteng, then one's known in part, so that's quite tricky. But I had quite an unpleasant experience with how my considerably better half was treated around the time of the birth of our son Sam, in that the attention was very much on myself as a medical professional, as opposed to on her as the patient, as the mum to be at the time, and it was really quite difficult for both of us, and awkward for both of us, particularly, well, bad for her and awkward for me, was the situation. So I relate certainly to some of the comments in the chat and from others, and Jenny and yourself, who have made comments around this particular issue. It is something that there's a level of comfort that one needs for being able to be in control of the situation, as opposed to the agenda being led in a different direction. And it is very much to do with professionalism.
Thank you, Richard. Go ahead, Jennifer.
Just another comment, it might not be quite so valid, is that I've found that when people have been treated themselves, they change the way they treat the patients. And an example of this was when I had the intestinal obstruction. My surgeon had one himself, and he didn't put a nasogastric tube down me because he'd felt how flipping uncomfortable it was, which was very interesting. So sometimes we learn from experiences as well. It's probably not related, but it's what happens. Sorry, thank you.
Thank you for that. I think that's a really valuable contribution here, because I think it's inevitable that on this platform, someone has either been a patient or had a family member that's been a patient. And I think we can all point out examples of professional and unprofessional behavior. And I wonder if any of you have looked at the one colleague who perhaps is an excellent surgeon and has great hands, but has a terrible bedside manner. And you wonder if you maybe tolerated that because you allowed for the skill to be there because you needed it. Whereas in another scenario, perhaps with a different pathology, where a little bit more bedside manner is required, perhaps counseling around cancer, maybe the good hands are not what's needed in that space. And that brings me into my next point, which is to just quickly share the next part of my screen. Give me a minute. Can you all see that?
Yes.
Yes, thank you. So I find it very interesting, you know, when people measure their professional behavior, what metric are they using? I wonder if you measure your own professional behavior or other people's unprofessional behavior against your ideal scenario, or if you measure it against the worst case scenario. I think we're like, oh, that's not so bad, I've seen worse. And perhaps we should be saying, that's actually not great. That's not what we expect of our profession, and we need to be doing better. And I'm challenging you to aim for the ideal that you developed your key positive professionalism traits, to aim it against the ideal and not being better than the worst case scenario. And stepping into that, I'm going to take you through some practical tips on 3 key areas. The first one is to look at some tips. Yes.
I think you're sharing your presenter screen instead of the...
Oh,
Other
thank you
one.
for helping me with that. I'm going to fix that quickly.
Pleasure.
Better, yes? Thank you for saving me there. Okay, Christine, is that good?
Yes.
Okay, so we're going to look at some tips to teach on professionalism. And before I start, I just want to ask, does anyone have experience doing this? Before I assume that given the state of play where professionalism is a challenge, that perhaps we're not doing anything, I don't think that's true. So I wonder, has anybody got any experiences around teaching around professionalism? Any comments at this point?
So I think, well, let's hear from Manta. Sorry. Manta's
Go
got
ahead,
a hand
Manta.
up.
Good afternoon. Sorry, I joined late. Yes, for me, I usually use cases to try and show them what can be done or what can happen. So I use real cases where sometimes I would then hide that I was the clinician actually involved in that case. So I'll put on even all my mistakes in that, but not allowing them to know in the beginning, but tell them right at the end when they've already actually judged and done all sorts of things, to say, by the way, that was me. So I just wanted you to learn from what I did, the wrong and the right, so that you can do better next time. Thanks.
Oh, that's such a wonderful idea, Mantua. And I wonder if the students see you in a different light at the end of a session like that. They probably do.
They do, because sometimes then they would say, oh, I was thinking the same way, but I felt so embarrassed that I can't say that because maybe it's not the right thing to do. And I was saying there's a lot of gray. It's not black and white. Sometimes it depends on the context, on what's happening at the time, but you still try and make sure that you respect and protect your patient. So yes, they do see you differently afterwards.
Thank you, Mantua. Richard, you wanted to comment? Did I miss that? Are there any other comments or experiences?
Yeah,
in
thank
this?
you.
Yes,
I just
go
wanted
ahead,
to
Richard.
reflect on just now. This is before COVID, but so a few years. When was it? It was about 2017, 18. We introduced some training around what we called the Voice Project in conjunction with the Rural Health Advocacy Project, or RHAP, of which the Centre for Rural Health, linked to the School of Clinical Medicine, was a founding partner. And I'll find the link and put it into the chat. But what the Voice Project was essentially around advocating for professionalism in the workspace, and went into some detail from both a legal and practical perspective of what to do when encountering instances of lack of professionalism in the workplace, particularly as a junior health professional, or even as a health professional student, because the matter of dual loyalty, Tina, is often a challenge that is faced, and we did bring this. When I say dual loyalty, to the patient one, and to the employer two. And of course, the patient should trump the employer every time, but it's tricky. It's a tricky balance to achieve. And so we brought that training into the GEMP 1 and 2 and into the BCMP space, the Bachelor of Clinical Medical Practice, the clinical associate space. But we couldn't. We struggled for it to take root. We still do so within the health system sciences track of the Bachelor of Health Sciences, but we've struggled for it to take root. And we can reflect on some of those details another time. Thank you.
Thank you, Richard. Are there any other comments around experiences here? If not, I'm going to just remind us, and I'm particularly focusing on what my experience in this area is that, you know, we all healthcare profession students at the start of their training usually take some kind of medical oath, and it's basically a declaration that marks an explicit commitment to ethical behavior. And this is a proud day. I mean, in the States, it's called the white coat ceremony. They get given a coat with their name on it. They get given a stethoscope. And we have a similar exercise where the Hippocratic Oath is taken by all students in the Faculty of Health Sciences. And this is supposed to get them excited about what's expected of them as a professional, and the lab coat and the stethoscope represent these professional attributes as clothing, and we're hoping that they'll carry them forward. And I find it interesting because the students come in very keen to do this, to get involved, to become these amazing doctors, and something changes as they migrate through the program. And what I'm going to do today is, you know, I'm going to look at my department's experience in trying to get these professionalism teaching assessment exercises. How are we doing? So I'm going to reflect on my space, and then I'm going to take you through a couple of other areas. So I looked at this because I thought we were doing a good job. And so what I'm showing you here is Ulwazi, which is our learning management platform. And there's a module labeled internal medicine. And within that is a whole 2 pages of folders that we expect the students to engage with. This is for self-reading. I mean, it's a mammoth task, the volume of content in there. But what I want to point out is that there are 20 folders, and professionalism is at the bottom. It's not even in alphabetical order, as you can see. Professionalism is just at the bottom because we kind of added it in as an afterthought, if I must be honest. We used to do these sessions as a dedicated teaching session with the students with interaction, and we didn't have time to do that during COVID, so we kind of shoved everything into a folder. And I think it says a lot to the students where we put this. And I mean, what is in these folders is excellent content. Communication with the patient, confidentiality, truth-telling, end-of-life decision-making. I mean, these came from the PBLs around professional development from before, and we put them into medicine along with a lot of other things. And if you open one of these folders, you'll come up with the theme content with additional reading and referencing our Health Professions Council's booklets. So, I mean, this is wonderful content, but we learned from our students when we interacted with them that documents do not change behavior. So I don't know that we can tick this box that we're getting this right. We're not with this strategy. So what could we do perhaps with what we have? What tools could you have access to that perhaps you already have and you haven't thought about using them in this way? Now, we mentioned case-based learning, and this is an excellent way to use everyday cases with real-world scenarios and ethical dilemmas that they're likely to encounter in practice. The thing is, you need to work through this with the students, and you need to get them to analyze, reflect on the scenarios, discuss the ethical issues, and develop strategies for responding to similar scenarios. So I think this is an easy thing to do because a lot of people are already doing this. Professional behavior is a doing thing. It's a thing we expect them to do. It's a way we expect them to behave. So we need to actually let them behave in our spaces. To learn how to behave, they have to behave with us. They have to act a certain way. They have to interact with us. It can't be learned from a lecture. And the experiential learning provides trainees with authentic activities that simulate or replicate real-world simulations. Now, we have simulation at WITS. I think we're only really effectively using it at the moment for skills-based training specifically. And please do correct me if I'm wrong around this area, but I'm not sure if professionalism training is covered in the simulation as we do it currently at WITS. I'm not sure if any of the simulation team are online and can correct me in this area.
Tatina, if you want me to jump in quickly here.
Yes, please.
We definitely do have professionalism training in the simulation arena in a whole lot of ways. We have patients, or fake patients, as it were, who are trained with specific goals in mind in terms of how they're managed and give feedback to students on their management. And they're also, for example, in interprofessional simulations where, especially where there's an overlap in scope of practice, where we can really highlight how people can become unprofessional when they become territorial over patient management, particularly. So both in practical hands-on sim and in flat screen sim development, we definitely have professionalism as one of the key areas where you can use simulation.
Shara, thank you for correcting me there. And I'm so glad to hear that, because, you know, as a teacher who's a clinician who didn't study using simulation, this is something that's easy for me to not even consider. And I think the possibilities around simulation and bringing it up into the higher years and into the postgraduate space has got massive potential. So thank you for highlighting that. Look, we talk about feedback and self-reflection, and providing feedback to the students and allowing them to reflect on the feedback that's been given is really important. But it has to go both ways. Giving feedback to the clinicians and feedback from the clinicians to the students. It's got to be a two-way street here. But asking our students to reflect on their behavior is a tricky thing to do in the moment, but it can be done in safe ways, such as journaling, guided discussions, portfolios, and or peer feedback. So there's a lot of ways around difficult conversations in feedback and self-reflection. Mentoring and role modeling, we discussed role modeling last week and the implications and how it's a powerful way to teach professionalism by modeling the behavior we want them to execute one day. But mentoring adds a different element where we take on trainees and we help them develop their professional identity goals and set goals for themselves and kind of hold them to it in that. And mentoring is something that's bandied about, certainly in my department, but hasn't really gained as much traction as I think it could in terms of improving on the development of our students and developing those trust relationships between students and faculty. And interprofessional education is definitely a tool that's shown to work because it does bring together different people from different spaces with different roles and responsibilities and a need for respect of each of those in order to work in a team. And that teaches people to behave in a professional way. And there are other benefits to interprofessional education, but for professionalism training, this is a particular area because one of the major unprofessional environments that exist are between the professions, where there's perhaps discordance between how clinicians perhaps feel about nurses, or nurses perhaps feel about medical students, or students feel about, etc. So I think that the possibilities, the toolbox here has a lot of strategies that we could adopt, that some people are adopting. But when it comes to teaching professionalism, there's no one tool that's going to work. You need to adopt a variety of strategies to get this right. But when you look at the literature, really, you need a multifaceted approach with explicit instruction and exercises that promote experiential learning around this area. And the two areas that have been shown to really work is self-reflection and role modeling. And a lot of us are uncomfortable having these conversations with ourselves and with our students and with our peers around behavior. They're difficult conversations to have. But I challenge that if we are having these difficult conversations with each other and with our students, we are going to get better at having these difficult conversations until one day they will be part of the training environment and they will be seen as just something that we do, not something that we have to think too hard about doing. And I've placed this image here because this professionalism issue can become quite a monster, and it's quite easy to get lost in the size of the problem. But I want you to remember that as an individual, your impact cannot be underestimated. You can change just one thing. You can look to yourself as a role model and change one behavior that maybe is coming across as unprofessional, or just add the discussion around professional behavior with your students at the bedside, or just take a tool that you're already using and add in a discussion around professionalism. Just one small step done by a lot of people in a lot of different places is going to have a magnitude ripple effect. So I just want to pause at this point and ask if there's any comment or additions before I move on. Just looking in the chat quickly. And I see there's a comment about colleagues who trained at UKZN after one of their clinical exams. He was worried about professionalism, and he stated that from year one in UKZN, they drilled about privilege and respect of the patient-doctor interaction. Sure, so they seem to be very, very deliberate about insisting on certain behavior. And the word drilling, that's interesting because it reflects sort of an army kind of sentiment. I'm not sure if there's any other comments at this point.
I just want to reflect on Jonathan's comment there, if I may, please, Tina, and just just to make the point that it worries me in Wits that I suggest that we drill the student about the privilege and or respect for the patient-doctor interaction, not necessarily from first year, to be honest, which maybe we should be doing, but certainly in GEMP 1 in the medical program, we do it from early on. But the irony is that we almost set ourselves up for failure, because if you role model so poorly, well, you set the ideal, and then the students have a certain expectation, and we almost make a mockery of it if we're not then good role models, because it just accentuates the differentiation between the ideal that we're drilling them in, Jonathan, and then the reality on the ground. And that's a dangerous combination, I suggest. Pause there.
Thank you, Richard. I saw a hand. Is it down? Okay. So from my side, let's look a little bit at, the teaching it is one thing, but we want to assess the professionalism of our students. And what are your experiences around getting this, doing this, getting this right, getting this wrong? Any comments here on individual experiences in their spaces around this? Do you think we're doing well? Do you think we're doing badly? Do you think your site's got it made? Any commentary?
Anastasia has her hand.
Anastasia, go ahead.
Thanks very much, Tina. Again, a very thought-provoking session. So I know, the comments around, documents not necessarily being the key to teaching skills such as professionalism. I totally agree with that. But one of the things that I find that documentation does, so within the NMFC program, we have weighted a professionalism assessment that the preceptors would give at the end of 8 weeks with the students, with them, around 5 Likert type questions, their attitude in the wards, their communication with patients and colleagues and seniors, their dressing, their, some of those things that may remotely or very directly link into professionalism. And yes, it is a document, but what documents will do, as opposed to not having a document, is that it creates an awareness that this is something, you know, much like the same way role modeling would, in an intangible manner, create a climate or an environment to you know, transmit a culture of professionalism. What the documents do for me, or what this document does for me, is that, first of all, it creates, for preceptors who are engaging, not going into the discussion of, you know, the different varieties of preceptors, but for a preceptor who is engaging, they look at these documents, they look at this 5-point Likert skills, and they know that this is something to look out for. And invariably, for some of them, it becomes something that they want to also role model, not consciously, but it just becomes something that this document has said, if I'm going to be assessing the students on this, then I'm aware of this for myself. And then on the flip side, for the students, knowing that this document is something that contributes a significant percentage to their clinical marks. I don't know if it's a fake it till you make it, or there is a genuineness, which is where the gray area is. But then there is a consciousness that, you know, my appearance in the wards matters. The way I would communicate matters. And we've had preceptors who have sent in assessments that literally denied a student SP or to write an assessment, which is what the students are always, you know, the whole assessment drives learning. But when a preceptor sends in an email and attaches this professionalism document and further details that this student or this happened, we found that with students, they're now very mindful or very conscious, a great majority of them, of the power that is in this document around professionalism. Thank you.
Thank you, Anastasia. Yanis, go ahead.
So just building on what you mentioned around reflection being a big component for professionalism, one of the assignments that we piloted at undergrad from first year to third year, but also now in the honors, is a continuous personal development assignment. So the aim with that is that students choose their own competencies. So we would give them a list of all the professional skills that they need to develop, which also includes some of the 21st century skills. It's not necessarily just professionalism, but they need to reflect on where they are at, and then so do a Jari's window and so forth, and then choose 2 or 3 skills that they need to develop, and then find open educational resources to learn more about about that, and then reflect on that, and that's done during the year. And then at some points we've got check-ins where students reflect again about, do they still want to continue with the skills or move on. And we do, and the idea there is to bring in 360-degree feedback. So, because the students get to know one another and so forth, with focused on the professional skills, and then also the learning in the workplace component, to get feedback from the employers and so forth, and then they can choose or stay with the same skills or move to something different. Now, just a bit of a, it worked really well for second and third year. We found that we removed that from first year because the students, while doing a SWOT focus group with them, we found that they really struggled with that sort of assessment at first year level. But yeah, and I'm piloting it now on the honor, so I don't know how that's I don't have feedback on that yet, but it seems to work really well.
Thank you, Yanis. Just remind me, which program are you referring to?
Sorry, that's our system science.
Health system science. Thank you. I like that idea. You know, holding each other to account and reflecting on how they're doing with that. Do you involve mentorship in that, in terms of guiding the students? Because maybe they're not sure that they're nailing it, or they think they are and they maybe aren't. So is there supervision of that process?
So we did bring in mentorship in the honors program. So basically, and that actually stemmed from the intern project that we run. That the intern said that they would like mentors. So we basically assign a mentor, and then they have to discuss that personal development plan with the mentor, and sort of check in on a monthly or 2-monthly basis around the performance, which also just makes sure that they stay on track with that. So yes, we've implemented that in the honors, but not in the undergraduate.
Thank you. In the interest of time, I'm just going to move along here a little bit. I really am appreciating that there's so many different experiences in so many different spaces, and there's benefit in sharing these experiences with each other, because we might inadvertently solve problems with different solutions we hadn't considered. Merwin, go ahead.
Sorry, that's a mistake. My apologies.
No worries. So I reflected on my internal medicine space to see how we're doing in terms of assessing our students' professional behavior, their attitude, their patient care, and teamwork. And what's happened in our logbook is initially we used to score patient care, teamwork, attitude, and behavior as separate components. They got separate marks for them, and they were quite highly weighted. And then we struggled to do it, so we put them all together and lowered the mark, because we were struggling to effectively assess this area. So what we told the students is that it's not important. We made it less important in terms of its weighting. Then when we assess it in our exams, in our OSCEs in GEM 3, we give it a mark, comportment or professional behavior at the bedside, but it's sort of 10 marks out of 125. And there is a proviso in our OSCE that a student can be failed for unprofessional behavior. But I haven't seen that happen yet. Clinicians are not brave enough to fail students on unprofessional behavior. They would rather fail them on a skill or a knowledge attribute. And we're telling them that with our MCQ papers, we're giving them 2 questions that cover ethics and professional behavior. And if they don't answer those questions out of a 70 or 90 MCQ paper, does it really matter? So my space really needs to work on this. So let's look at what strategies there might be in the toolbox that I hadn't considered for our space. Now, Yanis has mentioned a 360, which is multi-source feedback. And I think all of us are doing this in some way or another. We do get verbal feedback from our peers, especially when we're doing logbooks. How are the students? It's kind of a verbal ad hoc thing. But there are actual tools where you can get written feedback from an individual anonymously at a particular level, be it lower, same level, or higher, around a very structured set of things. So I want to be clear that when I'm saying multi-source feedback, I mean that structured thing, where we really are looking at a lot of attributes. And this gets feedbacks from various peers within your area and can extend to allied health professions that don't work, that are not necessarily working for you, but work with you in, for example, a hospital space. And the key with these tools is it's very effective in identifying areas for improvement, but only if you're promoting the self-reflection with a plan to improve on it does it really get somewhere. The next thing is to directly observe behavior. And this is to watch them as they interact and train, interact with patients and or standardized patients. And I often wonder if, because the students are being watched, they show their best behavior. So it seems to me to be a bit more a superficial exercise, and I'm not sure if it's always an accurate reflection. And I thought about, you know, in GEM 2, there is this OSCE where it's directly observed and professional behaviors are observed and check that they're doing it properly. And is that translating into the clinical space? Not always. And I'm wondering in the direct observation, Steph, what do we have access to? So, for example, in the emergency department, resusces are recorded. And that's the standard for some emergency departments. And then they do debriefing afterwards, and they reflect on what did everybody do, what were the roles and responsibilities, what went wrong, what they did well. But I wonder if we couldn't tap into a space like that and say the professionalism attributes. How did we do on that? Did you treat your team members with respect? Did you, the intern of 1 year, treat the nurse with 40 years of ICU experience with respect? Or did you disregard them because they're a nurse and you're a doctor? And I think that these observed things that are already happening give us an opportunity to tackle professionalism issues within what's already happening in the debrief. Portfolios, and Yanis has mentioned something like that, where we collect artifacts that demonstrates a trainee's professional growth and development. And these can be reflective essays, case reports, feedback from people. And my gut feeling is this has got a lot of value, but I don't think it's happening. And please correct me if I'm wrong, is because it requires a large amount of manpower to kind of observe and oversee and mark and check. But I think that something like this does have place in maybe smaller areas, maybe postgraduate areas where your numbers are less. But I think that this is a key step because it asks for self-reflection from students. Standardized patients assessments, and we do this well at WITS. We've done this for a long time, using either standardized patients or simulation, or particular scenarios, and we can test trainees' communication skills, empathy, ethical decision-making, etc. And usually a preceptor is assessing them and they are from the same area. But I'm wondering if we couldn't think of our standardized patients assessments a little bit differently and add in the patient giving feedback in this space and what role that may potentially have. The patient is the assessor in this, not just the clinician or preceptor. OSCEs have a lot of roles to test many things, and they have to be placed here. And it can definitely provide a comprehensive evaluation, multiple stakes, multiple assessment points that can be done. And I think it depends on what you put into the OSCE in terms of its value in professionalism training. And then we can use case scenarios where there's ambiguity or ethical decisions, ethical dilemmas, and use these case scenarios to have these conversations with our students. And I think assessing professionalism in health professions trainees is difficult to do, but it can be done, and it needs to have a multifaceted approach. And the key is you've got to get the students to do it themselves. You've got to get them to reflect. They've got to practice. Their behavior has to be observed with reflection, self-reflection, for it to be effective. Now, I've got a very busy slide up, and the point of putting this slide up here is because it gives quite a comprehensive list of tools with what they are and what area they're assessing in the professionalism realm. And this is quite a helpful thing to look at. And later I'll show you what we've created, where we've got some of these tools in a repository that you can pull them out of. But I think before I move on, are there any other strategies that people have tried that maybe I haven't covered to assess the professionalism of our students? Anastasia, I see your hand is up. Go ahead.
It's peer review. I don't know if it's here. So it's normally like a second step following maybe an incident report. And then the colleagues of maybe a student within a small group can be asked for their feedback in terms of how they have perceived professionalism of their colleague. So peer review. Thank you.
Thank you. And I see there's comments in the chat about areas of published work in public health, a doctor's perspective, a patient's perspective of doctor care in the public and private sector. Yes, I'm just seeing that. Richard, go ahead.
Just to add, within the context of the observed clinical encounter, the mini CX as you've listed here is one of the is perhaps the tool that we know best as clinicians and clinical preceptors. To flag what we also use within one or two of our medical programs, and that's the SNAPS tool, which essentially is the summary. Summary summarizes, narrows, analyzes, probes, plans, and then the self-directed feedback, or the self-directed way forward is the acronym for SNAPS. But my point is that it is the observed clinical encounters such as the mini CX are very much patient-centered. Centered around the patient and what the appropriate response is, and for having picked up the appropriate clues, as it were, from history exam, etc. Whereas the SNAPS tool is very much more learner-centered, and we haven't used it as well as we could have within the NMFC program. For example, I suggest, Anastasia, that we could have used it better, and maybe it's almost better at a first year postgraduate space, or course, where rather than undergraduate to a point. But it does allow one to focus a little bit more on the learner and then the professionalism around the learner within that, as opposed to these other tools being quite patient-centered and not necessarily picking up as much as we would like on the professionalism of the learner. Anyway, I'll pause there.
Thank you, Richard. Catherine Burns, please go ahead.
Thank you so much. I'm finding this so fascinating. Thank you for giving me a chance to speak briefly. There are 2 points. One is what I was trying to type quickly in the chat, and it's about the incredible work that I think colleagues across the road have been doing, which I don't really see colleagues in undergraduate education and in early graduate education drawing on that much, and that is the way in which they've created a cadre of trained patients and very complicated ethical work about how to get permission for this, who go into agreed upon spaces in the public and private sector to test different aspects of particularly patient-doctor relations. And they're really interested in people 5 years post-qualification. And they've come up with really rich results comparing them to other countries. One, of course, you may have read about around antibiotic prescriptions, but a lot of it is also around other encounters. A recent one is around postnatal depression, and there's ones around asthma and heart treatment, but a lot of the work is on psychosocial dynamics and on how the patient experiences this. So obviously the patients are trained individuals, often they're social workers or they have a psychology degree, but they're also looking for a whole range of clues about the encounter. Some have been so traumatized about the experience, for example, particularly around postnatal care, that they've needed counseling after their encounter, often with people who are currently still in the VIT system in some of the public hospitals around us. And so I think some of their findings would be really valuable, and there could be report backs more, because they do publish their work, but it never seems to cross into our spaces. The second point is that I do think that it would be very intriguing and fascinating to actually develop tools in our spaces of public teaching for patients to directly respond to their caregivers, the way that some of our well-run private hospital or public private hospitals are doing, such as Wits Donald Gordon. And I don't know if you know the paradigm that Sue Tager and a number of her staff developed around their transplant unit, especially for this, partly because there was such outstanding biomedical, surgical technology and interaction that patients were getting, but really poor forms of communications. There was a huge disconnect between surgical outcomes and between patients' experiences of care. And I think that would be really interesting. And they drew on a whole range of global literature to see if they could improve their interventions. And lastly, around the question of informality dress and courtesy and dignity and a range of these other complex issues. Many people are writing in the school space. There's Professor Stephanie Allays in our education faculty, who's an A-rated NRF scholar, who's looking at cultures of dress, of comportment, different understandings of dignity happening in the high school space. And she's coming up with really interesting theories. And I think it would be very interesting to think about the way in which people come in from high schools into university spaces now, and what the idea of dignity sharing means, and what it means in a decolonizing space, and how it still means a lot to people, but what does it mean, and what are the signals for it? So I'll keep quiet now, but these are some of my rich thoughts, my thoughts prompted by this rich discussion. Thank you.
Catherine, thank you so much. Could I please ask if you have time to share those works that you've referred to on the chat for us to take a look at? Thank you. Colleagues, the last part of our session is to really look at tips to assess professionalism in our teachers, in our faculty, in us. How do we do that? I'm going to skip this part because we're running out of time and I do want to get to a critical part of this talk. So my experience really with assessing faculty and professionalism is it's very much whispered in corridors. That one behaved badly, this one behaved badly, and often the behavior is well known, but sometimes not to the individual themselves. It's just the topic of extensive coffee shop, lunch hour, etc., conversations. And this is my personal experience that I'm reflecting on, and it may not reflect yours. But what I wanted to bring into this space, which might help, is Giannis mentioned this earlier, and I just want to reflect on the value of looking at the Johari window model. It's a really helpful tool because it's a simple visual reference for examining your personality and improving your understanding between other individuals. And it helps develop self-awareness, but is also a personal development tool that builds better workplace relationships. And the key part of this Johari window is the areas that are known to self and known to others. These areas need to be harnessed and worked with. And those that are not known to self but are known to others, known as blind spots. I can't tell you how many interactions I've had when I've called in a student, peer, anyone, on do you know that the way you behaved was perceived like this, and they honestly were shocked. And highlighting blind spots and finding what these blind spots are and minimizing them and getting to learn about each other. And I pop this up here because I think it has value in those that are managers in the spaces that they're in, and to look at team development and team building exercises that look at these types of personality traits, which often get brought under scrutiny, especially when there is unprofessional behavior. I try to look and see is how as faculty are we assessing professionalism in each other. And again, this is from my personal space as a clinician in the medical program in the School of Clinical Medicine, very small little area. And I kind of looked, and what I found, which was very interesting, is that most of the professionalism gets done accidentally in the teaching assessments. So areas of professionalism are covered in teaching assessments. So you kind of need to have a teaching assessment done, which is already a thing that isn't broadly done within my faculty. And within those, depending on what tool you choose, some attributes will be touched on in terms of how you behave, your empathy, your concern for others. So for me, in my space, it seems that professionalism is assessed more in an ad hoc way, and perhaps is only brought up when unprofessional behavior has come up. So I'm going to just pause there and ask if anyone has a different experience of assessing professionalism in their space. Just looking in the chat. So maybe we'll reflect on that as we proceed. And just to look at, when we're looking at our teachers and faculty and us, what else is in the toolbox that we need to consider? I know we keep bringing up self-assessment, but it is an absolutely vital tool. And educators need to reflect on their own professional behavior and attitudes and identify areas for improvement. I want to take that back a step and say, faculty need to look at themselves and say, are they part of the problem? And look at what they're doing well and what they need to work on. And to really just help guide where necessary. But it's difficult to tackle colleagues that perhaps don't want to look inwards. But this is definitely one of the best strategies to improve in the professional development of faculty, is to get them to look at themselves on a daily basis. And usually this only happens in the negative space. Unprofessional behavior is being called up, and whether they do or don't look at it depends on the parameters and how it was handled. The next is peer assessment. And this is a lovely thing. And, you know, I could think of maybe one or two colleagues that I'd asked to come and check and see in the teaching space how I'm behaving. And I can tell you, it is incredibly stressful to be under the microscope like that with someone that you trust. But there is so much value that your colleagues can provide that perhaps you didn't know that you were doing, or you didn't know that you were doing this well or badly. And these diverse interactions with your peers really does promote collaboration and feedback. Student feedback is key. And like I've said, my experience at the moment is it's very ad hoc. And this needs to be a bit more deliberate, where we are collecting data from students, not only on what the clinicians or physios or BCMP educators or any of the healthcare workers, teachers, what they know and what they can do, but how they behave and their attitude towards the students, the patients, and the training space. And a multi-source feedback tool, or a 360, it has many names, is definitely something that's helpful in terms of having categories of things to reflect on. What else is in there is direct observation. We're very quick to point fingers, and we need to be looking at ourselves and having others look at us and holding us to higher standards. And then I think a key thing for me is professional development plans. I reflected on if I've had mentors over the years that sort of have helped me to develop and have a strategy, a 5-year goal, and help put plans in place to get there. And from a professional perspective, I don't know how many people have access to these people. I certainly don't. And this individual coaching or mentorship it develops trust in that relationship. And when you create excellence in your teachers, that has an exponential effect, because they become better role models. And then the students have a better experience, and then they become better role models. And the impact is massive. Just taking one individual to improve, to help them see things they didn't know about themselves, to help them channel them into areas that can help them develop in the areas that they need a bit of work on. And to develop these kinds of goals is key in getting us to be the best versions of ourselves. But I also think that one key thing for faculty that I would say in this professional development is to just change the mindset of treating our patients as people and not as patients. And Richard articulated this well last week. He said, if we treat our patients as people, we win every time. If we treat them as patients, sometimes we win and sometimes we lose. And I think that's key for faculty and engaging with faculty as well. I'm going to just bring in this tool that exists that I'm going to ask Richard to speak to for a moment.
Tina, thank you. I think just to reflect on your good inputs around you know, what's in our toolbox. So to reflect first of all on two instances where we've of things we've tried and we're still working to get it right. The first is that within the NMFC program, we introduced, as Dr. Ugawanye has said, the multi-source feedback that counts for a certain proportion of the students' mark. And I know we're talking now about faculty, but just to reflect on the students and the challenges with receiving that multi-source feedback is that one of the things that has challenged us is that it has worked out on a practical level that it is we're looking to receive sort of a cross-sectional at a moment in time feedback from multiple different parties and on a student's performance, and that's always tricky purely from a logistics and efficiency perspective. And I mean, there are always little things that under Dr. Ugowanyi's good leadership in the NMFC program that we've tried to improve things, not least, for example, by including photographs of the students in the preceptor guide up front in the preceptor guide, and then that reminds people of who the students are, and then they can give the feedback. And Anastasia, I bet you chuckled a little bit at Tina's form being at the bottom of Ulwazi, and I note that, and it's in our preceptor guide, I think it's at the bottom as well, isn't it, in terms of our interprofessional, our tools that the preceptors use, or assessment tools that the preceptors use. But the challenge is that often it's fallen back on just being it not being it having to be at a cross section in time, and B, then it falls to the HOD in a particular facility to do it, as opposed to multiple people giving feedback on the students. And so therefore, from this perspective, with you raising doctor, the point is that can we use technology appropriately to capture over a cohort of time through a rotation inputs from different people on these students, and yes, even if we are using peer review or multi-source feedback, or that we are able to do it through of faculty as well, we're able to do it using technology to capture at any one particular point in time when a student is interacted with by faculty, or indeed even if faculty are assessing other faculty. So it does have to be, in my view, we've got to look at it being technology driven in some way, or technology enabled. And the second point around that is that are we able to do it that it's driven by the individual who is to show to demonstrate professionalism. So we have to build the culture of that, of allowing it to be self-driven. So if, yes, a portfolio, for example, within a portfolio, within a teaching portfolio, do we have enough in there, and Shira can help us with this, that reflects that reflects professionalism as an individual against certain criteria, and reflection on that. And technology again can assist us to capture that. And then doctor itself, I mean, if I shared my screen, and hopefully I can find it here, let's see where it is. This is in fact not doctor. This is ComCare, which is done within the BCMP program, but it's something similar to the doctor process, and that we capture the thoughts of faculty within the, if you can see my screen, within this particular free response, and then they rate a student to be able to capture their performance, their communication and teamwork, their professional attitude and behavior. And then at the end, you'll notice in ComCare, which we don't actually do in doctors, that you're asked to put in a preceptor password. so that we can that's known to you alone as a preceptor, and you shouldn't be sharing it with the students, and therefore, we're sort of authenticating that response. Because then it does allow, if you're doing that, the faculty to then capture something on almost a programmatic basis as they go through, which the literature is quite clear that we should be doing in terms of all of our assessments, or that it's an important tool of all of our assessments, and that we can try to capture that. Now, at the moment, Doctor is doing the same, but what we've introduced it in GEMP 1, and we're asking for a voice note from the students from their nursing visits, and those voice notes are quite simply used for them to be, at the moment, to be reflecting on what activities they're doing within the nursing visits. But we could structure those voice notes that then are transcribed and written up in a report for distribution to HODs and clinical preceptors. Those voice notes we could be structured in more of an appropriate manner to capture by way a self-reflective element around their professionalism. So my two main points to summarize, and one is that can technology enable this process? Point number one. And point number two, and I put this as a question really, do we not need to build the learning excellence culture so that it is driven by faculty or driven by the student, as opposed to putting measures in place whereby one is evaluated by others? Because I just see that I'm not sure that is as easy as we would like it to be, although it may be more valid and reliable at the end of the day. Can we make it a self-driven process, a self-reflective process around professionalism? And we don't have time, so let me pause there.
Thanks, Richard. Yes, I'm very aware that we are over time, and I'm just going to show you my last point of comment, which is that I think we all have a lot to add to the conversation, and trying to scramble around and figure out what does and doesn't work. Perhaps having a repository where we can put these tools that we're using that are valuable into these spaces. So I've created a drive that contains various bits of information, and all the tools that have been mentioned today, particularly a 360 assessment. There are tools to assess the attitudes towards professionalism in your training space, if that is something that you want to do. These are all existing tools, and to tap into these and to contribute to them. So if you would like to contribute to these spaces, please put your details in the chat, and I'll add you on, and let's collectively put together something that we can all share to help us to do better at this than we currently are. And this brings me to the end of my talk, which is thank you for your time and your concentration and your interest and your engagement today. I know we've gone terribly over, and I apologize for that. I will do better with this next week, but I'm going to ask you to just, when you're assessing your professional behaviors, bench your behavior against the ideal in your head, not the worst case scenario. We as faculty have access to a toolbox of strategies, and we need to share these amongst each other. And to tackle this problem effectively, we've got to work together on this. Do not forget your impact as an individual, and how much you can change, how much a change that you make, as small as it may be, will impact on students and future students. And to say, last week we started this process, and next week is our last part of this process. So do join us next week for the final part of the series. Professionalism is an everybody problem, and we really need to keep reflecting on how to do better in this space. And thank you, colleagues, for your attention. I don't know if there are any comments at this stage before I close up, but do put your emails in the chat, and then I'll add you to that group, and we can collectively share strategies to get through this. I see that there's comment around how it is tough to create a culture. I think that's true. I just think it starts with one person who convinces another person who convinces another person. And eventually one day you've changed the entire space. And I think it's to hang in there and keep trying, even at an individual level. Richard?
Which is exactly what we're trying to do with this conversation, is hang in there, because this is the first of what we hope is a number of conversations, not so, Tina, and with this
Yes.
professional learning series, and just to thank you very much, and to reiterate your call for the colleagues to join us next week. And we were reflecting today, Tina and I, that can we use some of the time next week, colleagues, to craft a way forward for us as to how this we might be able to take this conversation forward, and your inputs and ideas will be very welcome, and that's when we get to that particular point next week. Thank you.
Thank you, colleagues, for your time. Thank you for all the comments. I'll add all of those that want to get involved, and if you forget, you can just email me and I'll add you later. If you want to add anyone else, I can do all of that. But thank you for your time, and good afternoon, and we'll see you all next week.